The dry type is much more common, and almost everybody starts with the dry type. And then about 20% of people will convert from dry to wet. And what we see when we do an eye exam for macular degeneration is in cases of wet macular degeneration, we see accumulation of fluid and blood, and that's why it's called wet. So here we have a model eye. So let's open it all the way up, and you'll see here this pink layer on the inside is the retina. The retina is the inner lining on the inside of the eye, and the center of the retina, which would be about right here, is the macula. And you can see also there are a lot of blood vessels in the retina. Wet macular degeneration is when we see fluid accumulate right here in the macula, and it causes distortion of the macula. And when the macula gets distorted, it makes the vision distorted. So instead of having lines that look straight, a line will start to look crooked. Door frames, window frames, things like that. And frequently it's an abrupt onset of vision changes. And that's when we know we need to do something. Injections are the treatment for wet macular degeneration right now. The treatment consists of a regimen initially of monthly injections into the eye, and we numb it up so it doesn't hurt. We do it right in the office. We use a tiny little needle. We inject the medicine right into the inside of the eye, and then once the medicine's in the eye, it goes all over the inside of the eye and makes the leakage get better and makes the fluid go away. And when the leakage gets better and the fluid goes away, the lines start to straighten out and the vision clears up and things get better. We now have medicines that last longer, so the injection frequency doesn't necessarily have to stay at once a month for as long. We can more quickly transition to every 2 months and every 3 months with the newer medicines. But depending on how the eye responds, sometimes we still have to do quite frequent injections. One thing to know about it is the earlier you catch it, the more likely we are to be effective at getting it treated. Because left untreated, that fluid buildup and that blood leads to scarring. And once you get a scar, the injections don't work so well. But things are getting better. The medicines are working better and lasting longer as time goes by.
Wet age-related macular degeneration, or AMD, is a long-lasting eye condition that damages the macula, the small area near the center of your retina. When new fragile blood vessels grow under the macula and retina and leak fluid and blood, this causes the macula to bulge and lift up from its normal position, resulting in vision problems when looking straight ahead. If you notice that your vision is changing, see your eye doctor right away. There are treatment options, like injectable medications and laser therapy, that can help ease symptoms and slow the condition's progression. Routine injections of anti-angiogenesis medications can help stop the bleeding and lessen fluid leakage in the eye. They work by blocking VEGF or ANG2, which are proteins involved in new blood vessel formation. Photodynamic therapy uses a light-sensitive medicine along with a laser to damage the abnormal blood vessels. A less common surgical option uses a laser to coagulate or thicken the blood vessel to stop leakage. While surgery targets the existing blood vessels, it does not prevent new vessels from forming. Meet with your doctor to discuss any symptoms or vision changes. Early treatment may help maintain or even return some of your vision.
Of Iowa. We first place a topical anesthetic into the eye, and this is followed by a topical antibiotic. Next, we inject a small amount of xylocaine subconjunctivally. Usually this is in the superior temporal quadrant. We raise a bleb of the anesthetic and allow this to remain in place for 3 minutes or more for anesthesia. While the anesthesia is taking effect, we paint the area of the conjunctiva where we're going to inject with 5% povidone iodine. We then remove the ranibizumab from the bottle using the large bore syringe provided by the company. This large syringe is then replaced with a 30 gauge needle, and the syringe is checked to make sure we then have a 0.05 milliliter or 5 milligram dose. A lidded speculum is inserted into the eye. An area 3.5 millimeters from the limbus is marked with calipers. Often we'll replace 5% povidone iodine prior to injection. The 30 gauge needle is then directed into the middle of the vitreous cavity and the drug is slowly injected. A cotton tip applicator is placed over the injection site to prevent reflux of fluid or medication. The lid speculum then is gently removed and the eye is irrigated to remove any excess povidone iodine, which is an irritant. An antibiotic drop is placed. The vision is briefly checked to make sure there's at least light perception after the injection. The patient is then instructed to go home and continue the antibiotic drops for 3 days.
Of choroidal neovascularization. Evidence suggests the complement system also plays an important role in inflammation and wet AMD. The complement system functions as part of the body's innate immune system to provide protection against infection. When triggered, a biochemical cascade is initiated that amplifies the immunological response and destroys bacterial and viral cells. Complement factor H, or CFH, is a critical inhibitor of the complement pathway, downregulating complement activation, potential inflammation, and tissue damage in response to immunological triggers in wet AMD. Normal CFH proteins bind with activated complement to prevent inflammation. Recent studies have demonstrated that a CFH gene variation can account for 50% of the risk of developing wet AMD. The CFH gene variation in wet AMD interferes with the ability of CFH to inhibit and bind with the activated complement on cells of the retina, the Bruch's membrane, and the choroid. Therefore, mutation in CFH fails to downregulate complement-mediated inflammation, leading to overexpression of VEGF and/or direct damage to RPE cells. In wet AMD, this overexpression of VEGF caused by uncontrolled complement within Bruch's membrane and the RPE leads to the formation of CNV. Like inflammation, hypoxia is a major cause of overexpression of VEGF in wet AMD. The choroid is the main source of oxygen and nutrients for the retina and is also the only source of blood supply to the fovea. Bruch's membrane naturally thickens over time, separating the RPE and outer retina from the oxygen diffused from the choroid. Research has also shown that the capillaries of the choroid may be smaller than normal and fewer in quantity in patients with wet AMD, which reduces blood supply. Hypoxia leads to overexpression of VEGF by the RPE, which can cause irreversible damage. In wet AMD, VEGF plays a significant role in the formation of blood vessels that grow abnormally and leak beneath the macula. Overexpression of VEGF initiates the abnormal growth of choroidal blood vessels through Bruch's membrane and into the subretinal space. These choroidal neovascular vessels leak blood and fluid, forming the characteristic lesions of wet AMD. Due to the chronic nature of these risk factors, patients with wet AMD may be at constant risk of recurrence of leakage, even after months of being dry. Therefore, consistent control of VEGF can be essential to minimizing the risk of recurrence of CNV in patients with wet AMD.